I'm just finishing out my third year, as you guys are just finishing out second year. I apologize sincerely for the delay. I tried to give myself a big buffer, but as you'll come to find out next year, the days tend to run more than what you planned for. So anyway, we can get started so that way I don't keep you guys too long afterwards. And then if anyone does want to stick around, I'm happy to talk about like third year and rotations and things like that after we finish. But for now, I'll just share my screen and then we can get started. All right, cool. Okay, can you guys see? Good. Okay. So I'm hoping for this to be as helpful as possible for you guys. And with that, I'd like to, give you guys the permission to, call out with any questions you might have. I'm hoping to ask questions of you guys, so feel free to call out any answers that you think of, and that way we can make it a little bit more of a dynamic presentation and try and make sure you guys get the most out of it as possible. So today we're going to be talking about some tips for your orthopedic exam. I know you guys are getting ready for your third year rotations. Are going to be in a few months after you guys take boards, which is very exciting. This has definitely been the best year of med school so far. First years were great, but getting out into the world has been a really good time. So when you guys do get to an orthopedic rotation or even your internal medicine or primary care rotations, you're going to be doing musculoskeletal exams and neuro exams. So I'm hoping to cover some of that information today in a way that will hopefully be just kind of a brief review of everything that would be important for you in a foundational type of perspective. And it will hopefully kind of reveal areas where you might need to brush up on your studying and like spark questions for you for areas that you want to do a little bit of further studying. So I kind of started talking about the goals a little bit. So we're going to review specifically the shoulder and knee exams. And we'll, of course, cover introductory anatomy. We'll go over some classical pathologies and help get you guys a little bit ready for some of the PIM questions that are going to come your way. We'll cover the associated histories of those. We'll go over the physical exam, what you guys learned in your doctoring courses. The IPROMS approach for the MSK exam, honestly, is really great. And it's a great mnemonic when you are attempting to present a patient too, especially, you're going to take your notes during your exam and during your history, and that's great. But sometimes you might be expected to present without any notes in front of you. And so if you always remember the IPROMS, you can bust out a really nice, organized musculoskeletal presentation pretty much every time. And it's going to cover all the essential information. And then I wanted to just go over a few ultrasound things. I understand you guys are probably pretty involved with ultrasound this year. I think you guys are the class that started getting probes and everything. So you guys probably at this point know more about ultrasound than I do, but we can go over a couple sample images of anatomy and pathology. So that way, once you do get out on rotations, if someone asks you, hey, what's this on the ultrasound screen, you might be a little bit more prepared. So we'll start with the shoulder assessment today. So as mentioned, we're going to do some brief anatomy. That, of course, means some anatomical planes. So I'll kind of go through some of this stuff quickly because I know you guys are probably pretty sharp on this still, especially being interested in orthopedics. But when you start doing your exams, you're going to want to make sure you remember the terminology such as inferior and superior, anterior, posterior, medial, and lateral. Proximal and distal are going to be really important, especially in the operating room when you're looking at one structure relative to another. When it comes to imaging, make sure that you're thinking about these anatomical planes. Important planes for orthopedics are, of course, going to be the coronal and the sagittal planes. And then there's sometimes you get transverse or axial planes if you're looking at some spine images or even of the knee. But when we're talking about the shoulder, those coronal and sagittal are going to be a little bit more useful for you. And then briefly reviewing some of the movements of the upper extremity. So we have flexion and extension, of course, abduction or abduction and adduction, medial rotation, lateral rotation, also known as internal and external rotation. And then this is the one that's important remembering when you combine all these together, that's circumduction. That can be kind of a common PIM question when you're getting started in like the outpatient setting with the MSK exam. And then, of course, when it comes to the inspection part of your exam, you're going to want to be able to use these words that are describing scapula movement. So when you're describing sort of the resting position of your patient, you might say the left scapula is elevated or it's depressed relative to the other one. You might say that the shoulders rest in a protracted position. Does anyone know what muscles are going to be tight if someone's resting with their shoulders in a protracted position?
Protracted, maybe like pec minor, some anterior shoulder musculature.
Yeah, so we're thinking about like pecs are probably going to be tight if someone's resting in a protracted position, and that might cue you into their history. Maybe they're lifting weights and that type of thing, and that can predispose them to some sort of degenerative shoulder pathology. So, and then of course, also important is going to be our upward rotation and downward rotation. This one, honestly, for me, the terms upward and downward have been a little bit confusing. But if you just think of where the inferior angle is going, you'll know for upward, it's going to swing out upwardly, and then for downward, it's going to come back down towards the midline. And then having an understanding of what this motion looks like. Generally, in a normal, healthy patient is going to be helpful for your exam when you're testing the abduction of your patient. If you're checking if they have any what's known as scapular dyskinesis, you're going to be able to start to pick up on that if one shoulder is not moving as smoothly as the other one. So of course, you need to kind of have a just a general understanding of what this looks like in the normal person, and then you'll be able to pick up on the abnormalities once you get out into your clinical setting. Okay, so continuing with the anatomy, this is, of course, probably not going to see many patients that actually look like the way Netter draws them. But I wanted to cover just the surface anatomy because this is what you're going to actually see when you're examining a patient. You're not going to get to see their muscles, you're not going to get to see their bones, but you have to be thinking about their muscles and bones. So we're going to start here with just what are some important things that you want to try and identify when you're looking at the surface anatomy of your patient. And we'll go through kind of different layers and the anterior and posterior perspective. I put little green boxes on things that can be clinically relevant for you. So, of course, deltoid musculature is going to be important. For those of you that are interested in sports orthopedics or even arthroplasty, the deltoid is going to be really important. You're inserting trocars through there for arthroscopy. For the joints interested individuals, when you're doing reverse shoulders, you're going to go right between this deltopectoral fold right here when you're doing your anterior approach to the shoulder. So that's an important muscle to be identifying in patients. Also an area of pain, of course. With the clavicle anteriorly, also the SCM coming up across the front of the neck, with the biceps, of course, and then the axilla we all know, and then anterior and posterior axillary folds. Does anyone know what makes up the posterior axillary fold primarily? What muscles?
Like the lat.
Yeah, so lat's going to contribute there. It's what gives us that Dorito shape that so many male athletes are seeking. Teres major is also in there too. And then of course on the front, we're all kind of aware, and we started talking about this already, is the pec musculature contributing to that anterior axillary fold. Okay, so now you're looking at your patient from behind and you're thinking about what they've told you, and you're trying to find on your exam what is the location of their pain. So you'll note the tricep posteriorly, again, the deltoid muscle, and then you're thinking about the trapezius, which you'll notice that there's a lot of arrows coming off of this main trapezius, because we all know from anatomy that it inserts near the base of the skull, but it also goes all the way down to the mid T-spine, right? So taking note of if they're having pain in this region, maybe it's coming from the trapezius, maybe it's in, can you guys see my mouse by chance? Okay, cool. So maybe it's not trapezius, maybe it's over here and it's actually more the rhomboids, but just taking note of where the patient's trapezius sort of lays. And then important for us, you can see this person has started to elevate their arm, but we have the medial border of the scapula kind of protruding out here. And then, of course, the inferior angle. And then I think, yes. Okay. So what is the spinal level of the most prominent cervical spinous process? We can go back here. Oh, no, wait, I can't go back because the answer's on there. But we'll go back afterwards because you can kind of see it protruding in the image. So does anyone know what level that is?
Is it C7?
Correct. Yes. So C7 is the most prominent. And in this one, it's honestly not the best in this Netter image, but when we get to removing the skin and looking at the muscular layers, you'll be able to see it. So I'll make sure that we go over that. And then I'm also going to ask you guys about the medial border of the scapula and the inferior angle. Does anyone remember? I know we covered this so many times in like OMM and anatomy, but does anyone remember the spinal levels for those?
T
T3.
T3 to T7.
Yeah, so got a couple answers called out. We started with C7 as the most prominent, up in the neck, and then scapular spine is going to be around the T3, and then inferior angle is going to be around T7. And then when I was verifying this, I actually found there was a paper. Some people did some research. It's actually pretty variable in terms of where that inferior angle lies. I think what's most important at the end of the day is that you stay consistent, because this is all going to relate back to the way that your charting is, right? So as long as you're, using inferior angle as T7 consistently, then your documentation will be consistent and your evaluations will be consistent. So when you're comparing patient to patient and normal to abnormal within the same patient, you'll have consistency there. So that's really important. I was going to say one more thing about that, but then it left me. So I'm sure it'll come back. So yeah, all right. So again, we're back to the anterior approach or anterior aspect. Or perspective of our patient, but now we've taken away the skin and we can start to see some of the musculature that we covered just a moment ago. So again, have the biceps, we have the deltoid, and then we have that deltopectoral fold or groove that I was talking about, where some of the neurovasculature lays, but it's also your primary sort of internervous plane for the anterior approach to the shoulder if you're doing something like a reverse shoulder arthroplasty. So that's a really important landmark to be familiar with when you're visualizing anatomy, but also when you're palpating patients and that type of thing. We can see the acromion coming off the shoulder blade, reaching around here and connecting with the clavicle for our AC joint. Got our clavicle, got our SCM again. You can see even the trapezius comes around to say hello in the front of the patient. It's not only big on the back, but we can see it on the front as well sometimes. And then we have our pectoral muscles as well. Important clinically is the serratus anterior muscle. Do you guys know what happens when you lose serratus anterior, or if it's really weak on one side relative to the other? What do you see on exam in those patients?
Is it
Scapular
the
winging.
winged scapula?
Yeah, exactly. Okay, so now we're back to the posterior perspective. The skin is gone, and this is what I'm talking about, because you're going to examine a lot of patients when you're examining the shoulder, you're going to be behind them a lot, and this is the image that you need to be able to conjure in your mind and think of all these muscles, because you want to be able to say, okay, I palpated this muscle, and I can correlate the areas of tenderness with what sort of mechanism they're telling me about in their history. What did they do, or what were they doing when they started to experience this pain? And before I forget, so we can see C7 protruding most prominently here, right? So again, deltoid trapezius, you can see it spans base of the skull all the way down the back. We have the levator scap, which is important clinically as well. Get a lot of tightness in there. And then we have the rhomboids, like I was saying, which are kind of lateral to the midline, but they're deep to the trapezius. Maybe the pain is coming from there if it's not more superficial of the trapezius. Supraspinatus, infraspinatus, teres minor, very important muscles, especially in the orthopedic shoulder world, right? We also have our teres major, which we mentioned briefly a moment ago, talking about the axillary folds. Okay. So we talked about rotator cuff muscles. Did anyone catch a rotator cuff muscle that I skipped on the last slide?
Subscapularis.
Yes. Very important. So I'll also ask you guys, can anyone name the four rotator cuff muscles as well as their innervation, their nervous innervation?
You lost me at innervation.
That's okay. That's okay.
Supraspinatus and infraspinatus for suprascapular nerve. Teres minor is axillary nerve. And what was the last one? Subscap.
It's in the name.
Oh yeah, subscapular nerve.
Yes, sir.
Yeah.
Okay, so this was for our muscle that I didn't mention on the previous slide. So this is an anterior view of the upper humerus or proximal humerus and the scapula with the subscap on it. And you can see the subscap is actually quite large. It's bigger than the other three rotator cuff muscles combined. And then here's the answer. So I didn't see the name. Derek, very good job. These are our four muscles innervated by suprascapular first, and then teres minor is going to be axillary. Subscap is going to be the upper and lower subscap. And then I didn't quite specify to tell you guys about or ask you guys about the actions of those muscles, but we have them listed here. Oh, and I think I also meant to ask what's the primary function of them when they're working as a team. And of course they're going to do, initiate abduction, externally rotate, internally rotate. But important thing to think about, and a very common PIM question is that they're actually acting to keep the head of the humerus fixed on the glenoid. So make sure you remember that one. Okay, and then bony anatomy. So this is super important, of course, in orthopedics when you're fixing fractures, or if you're doing arthroplasty and you have to cut this whole head of the humerus off. But important landmarks to know: greater tubercle, lesser tubercle. And for your own studying, you should really know what muscles attach to these tubercles. Supraglenoid tubercle. Does anyone know what muscle attaches to the supraglenoid tubercle? I literally just got asked this on my last OA rotation, and I was like,
It's a biceps tendon.
Yes. Yeah. Yeah. So it's going to be the long head of the biceps tendon. So we'll review that a little bit later. So then we have the acromion. This was mentioned earlier. You can see it as it's a continuation of the scapular spine coming around to the kind of superior part of the shoulder. You can see it connecting with the clavicle. We have the coracoid process. There's a few muscles that attach there. That's an important thing to know about as well. And then again, medial border of the scapula, inferior angle. This is our anterior view. From posterior view, you want to make sure that you can palpate these, the medial border and the inferior angle, of course, the scapular spine, and then around to the acromion, the AC joint, and the clavicle. Okay. All right, so that was just a brief review of the anatomy. I think I probably spent too much time on that, so I'll try and not do so much of that on when we go over the knee exam, because that's all stuff you guys can pretty easily study on your own. So systematic approach to the interview. The reason I say systematic is because when you're doing your interview, as you guys have probably started to pick up on from doctoring and stuff, but especially you'll see when you're working with patients kind of all day, every day on rotations, you'll see that kind of approaching patients with the same systematic approach is super important, because then you don't forget things. And you would think, oh, there's no way I would forget, to check for like right upper quadrant tenderness in this patient with cholecystitis. But then you do it because you change your routine or something like that. So I wanted to really reinforce for you guys the importance of approaching things in a systematic way, whether it's your interview or your physical exam. So when you're trying to get better HPI on a patient, what do you guys do? What is your system for getting HPI on a patient? And this is not some like complex thing. This is like I'm asking for, what is your simple trick to help you remember?
Bold cards, fed tacos? Is that what you're asking? Okay.
Yes, sir. So when you're getting HPI, I still use bold cards. The residents still use bold cards. The attendings still use bold cards. It eventually, of course, becomes part of your normal flow and the normal way that you think when you're interacting with patients. But when you guys are, early on in third year, and, the resident gets bold enough to send you down to the ED by yourself to go and interview a patient, you don't want to be kind of racking your brain for things. So like while you're walking down to the ED, write down bold cards on your paper or on the notes on your phone, and that way you just have it and just make yourself go through it. Because if you don't, you will forget something, and then you're going to be writing the note later, or you're going to be trying to present to your attending, and they're going to say, "Oh, well, did it radiate?" And you're like, "Oh, I didn't ask if the pain radiated. Darn it." So it's better to just write things down at first, and then you'll really get the hang of it. And then I meant to ask you guys about this, but if you're getting general medical history, this is not a known mnemonic unless you're me, because this is the one that I use, that I kind of made it myself. So I feel like this has sort of a logical flow in terms of the way it progresses, because once you ask about someone's HPI, you're going to want to know what other medical conditions you have, and logically continuing with that, what medications are you taking for those medical problems that you have? And then the rest is this sort of general medical history, their allergies, surgeries, have they ever been hospitalized before, that type of thing. So you can see I bolded the letters for you. It spells out MASH FSTVS, and that doesn't really spell anything very nicely, but the way I say it in my head is like MASH fast TVs. And that way I just always can remember all the letters. And once I get the letters down, I can remember the words, and then we can go from there. So use that if you want. Definitely use bold cards, and then if you feel like taking that. And then someone mentioned fed tacos. This is still super important. I was just I'm on internal medicine right now, and I was just doing a consult in the ED yesterday for a patient that had cholecystitis, and we needed to ask, what are your dietary habits like? Because that's super important for the workup of cholecystitis. Have you been eating greasy foods lately? That type of thing. Needed to also ask about sexual history. When was the last menstrual period? How many kids have you had? That type of thing. So these are the mnemonics I like to use, and this will get you pretty much everything you need in a history. In special situations, you'll be able to branch out from this, but the main thing I'm trying to communicate is that you should figure out what you like to use, or what you're going to at least start with, and commit to it, and then you can slowly adapt it over time, but just try and be as systematic as possible. when it comes to your interview. So when we're working with a patient that's in your clinic or you're in the hospital and they have shoulder pain or some sort of shoulder problem, what are some classic shoulder problems that you guys think of?
Adhesive capsulitis, supraspinatus tear. Those first two to rule out, basically.
Yeah, those are super important. What if you're dealing with like an older patient? Supraspinatus tear is common in them, right? Chronic rotator cuff tear. But what's a classic thing that affects the entire body that is also in the shoulder?
Osteoarthritis.
Yeah, of course. So those are some important things. Just trying to get your brains warmed up in terms of the pathology. This is a nice picture that Netter so kindly provided us. So if you're working probably in the outpatient setting, you're dealing with an athlete and they're talking about falling onto their shoulder, such as this football player, you might be thinking more about the AC joint. This is a really big one with throwing athletes, swimming athletes, volleyball, javelin, I guess, is also throwing. Anybody who puts their arms over their heads for their sport, you're going to be thinking about rotator cuff tears. You're going to be thinking about impingement. You're also going to be thinking about labrum pathology. Okay. And this is also kind of covered here with instability being common in shoulders. Instability is kind of on the same page as labral pathology. And that's going to be common in these throwing athletes too. So I'll try not to go too deep into this because this is something you guys can come back to and even like screenshot on your phone or whatever for when you get to the outpatient orthopedic rotation. But this is a nice little chart that essentially goes through the bold carts for a patient with shoulder pain. And depending on what answer you get in this column, that can kind of give you some tips on what type of pathology you might be dealing with. So I'll just briefly cover a few. I mentioned in the older patient with shoulder pain, you might be thinking of a rotator cuff tear, specifically like a chronic full thickness tear. You might be thinking of osteoarthritis or even adhesive capsulitis. And then in these younger patients, especially if they have a throwing sport history, you might be thinking of instability or labral tear. So that's kind of how this chart works. And for the sake of time, I'll allow you guys to go back and review that. So then when it comes to the physical exam of the shoulder, I mentioned the IPROMS approach being super important. You have your history already. You went through whatever mnemonics it is that you guys have decided to commit to for the rest of your lives. And then you need to examine the shoulder. One of the most important parts of the shoulder exam, and for those of you that end up rotating with Dr. Atkin, you'll know that the most important, or not the most important, but one of the most important parts of the shoulder exam is the neck exam. So why might that be important? Why do you guys think inspecting the neck when someone has shoulder pain is important?
It can be pathologies like cervical radiculopathy that radiates down to the shoulder region. It can be osteoarthritis of like the facet joints within the neck causing radiating pain to the shoulder.
Yeah. So that's a really big reason. A lot of shoulder pain can be emanating from the shoulder or it can be radiating to the shoulder. And so if the pathology is actually in the neck, we want to make sure that we don't miss that. And so we're going to make sure that we examine the neck. Another reason is because a patient might have on their chart and when they called the office to make the appointment, they said, I have shoulder pain. And then you're sitting there with them and you say, can you point to where it hurts? And they point right here. And they're like, it's my shoulder. So some patients, it's just in terms of like medical literacy, you might get kind of different things. I had a patient on one of my orthopedics rotations that was there. Her chief complaint in an outpatient clinic was shoulder pain, and she had a broken rib. And so, thankfully, we caught it. But you just kind of never really know, and that's why the systematic approach is important too. Because if someone says shoulder pain and you get locked in on that, and you don't systematically approach their body, you might miss that cervical radiculopathy or the fractured rib. So super important there. You want to make sure you examine the neck, and you don't have to be super extensive with it. Just the classic, like we do in OMM, range of motion, flexion, extension, rotation both ways, side bending both ways. And when you do your side bending both ways, you can even add in a little bit of a Sperling maneuver just to quickly check for radiculopathy. And then we'll move into the shoulder exam. So I mentioned the importance of being able to, with anatomical words, describe the resting position of one's shoulder. That's going to give you a clue into what tonic forces are acting on their shoulder when they're at rest, right? So if they have really protracted shoulders, then you kind of have an idea of what their biomechanics might be like. They have really tight anterior musculature. So being able to describe, are they internally rotated, externally rotated, elevated, depressed? Is there symmetry or asymmetry in their shoulders from side to side? That can be coming from muscle bulk, muscle atrophy. There might be signs of trauma. For example, on a patient that has like a bicep tear, they might have the muscle rolled up. We call that the Popeye sign. They have a big bulge from the muscle rolling up. Or if they're maybe they have some sort of rotator cuff tear and they're not using the arm as much, you might start to see some atrophy in the deltoid or in the trapezius or something like that. Sorry, I didn't mean to go back there. Okay, so that's just a few notes on inspection. I mentioned the neck, the shoulder, and you also want to make sure that you move down at least into the proximal upper extremity down to the elbow. But if you're being really comprehensive, you'll go, neck all the way down to the fingertips, and then even some of the back as well, right? Including that thoracic spine. So then palpation. This is kind of the flow that I like to use, and that's the reason the next couple of slides will be kind of dense in terms of words, but I wanted to make it so that you could just like screenshot it, and that way when you do get to that rotation, you could just quickly pull up the picture and say, oh yeah, this is the flow that I learned about that one time, and hopefully it'll be helpful to you guys. So the way I like to do it is start with the paraspinals, and then the spinous processes. So we're kind of finishing up our neck exam here. I've already tested range of motion, non-palpating. Then the upper trapezius, medial scap, or rhomboids as well, scapular spine, and then up to the acromion, as I mentioned earlier, AC joint, clavicle, sternoclavicular joint. Someone might have pain there right on the sternoclavicular joint. And then you can move back to the arm. You can feel the greater tubercle on the humerus, kind of palpate that through the belly of the deltoid, the bicipital groove, sits muscles, rotator cuffs, right? And then I'll go to the next slide just very briefly so you can kind of visualize that better. So we're starting at the paraspinals here, right? Feeling through trapezius into the paraspinal muscles, feeling down the spinous processes, as low as what feels appropriate depending on the history you've been given so far. And then you can also feel the rhomboids. Sorry, I keep clicking. And then inferior angle of the scapula, you can work your way up the medial border, palpating all along here. And usually when I start, I say, hey, just tell me if any of this is especially painful for you. Okay, so working our way up the medial border, we can feel the muscle belly of the supraspinatus. We can feel infraspinatus. We can feel teres minor. And then we can work our way across the scapular spine, around the acromion, and then to the AC joint, and then to the clavicle. And then we can do some of those anterior points, this sternoclavicular joint, and then anteriorly on the humerus here, I know we're looking from the posterior aspect here, but on the front is going to be where the greater and lesser tubercles are, and then the intertubercular groove you can feel there if they have like biceps tenosynovitis or something like that. You can palpate those areas as well. So that's kind of our palpation pathway. That's the way I like to think about it. And you can do the same with your inspection. And then range of motion for the shoulder isn't really anything too crazy. So you can test shoulder flexion. Just ask the patient to lift their arms out in front of them. And then from there, let me make sure I can see what you guys see. So you have them do flexion and their arms are like this, right? And then you can ask them just to go straight into external rotation. And you can sort of describe it as a goalpost position. So it's a very easy flow for the patient. If you're dealing with like a 75-year-old patient that's really frail, you don't want to be like arms up, then arms down, and arms up and arms down. So flexion and then external rotation, and then arms behind the back for extension, and then internal rotation. And to do internal rotation, I guess I'll be kind of silly and I'll show you guys. Well, you'll lift their arm behind their back. And then the reason it's important to know, this is the thing that I forgot earlier, to know the level of the inferior angle and the scapular spine and other important landmarks like the iliac crest. When you grade internal rotation, it's kind of hard to put degrees on that, right? Because they're sticking their arm up behind their back. So you might say, with someone who's, really injured, internal rotation only to, the right buttock or to the right iliac crest or even to the right inferior angle of the scapula. And if you know what you always say the spinal level for the inferior angle of the scapula is, you can say internal rotation to T7. And that way you have that and you have sort of an objective measurement that you're always using. So yeah, I knew that would come back to me at some point. And then abduction, depending on how, the functional status of your patient, you might be able to get them to do, abduction all the way up overhead. I find with older patients that already have some sort of shoulder pathology, this is pretty challenging. And honestly, even getting them to do flexion directly in front of them is challenging. So sometimes it'll end up being kind of like in the middle of the two, like flexion and abduction. And some will just document that as elevation, and it's not necessarily one or the other. So that's just a note to think about. And then we kind of covered this already. So then this is another one of those slides. I know it's like really ugly to look at, but I was hoping that you could just screenshot it, and that way you don't have to come back to a PowerPoint or, Google or whatever. You can just have like a little picture saved on your phone or something like that. So you've done your inspection, your palpation, your range of motion, and then the S in IPROMS is going to be our special tests. And I like to break that up into a couple different categories. The first thing is going to be dermatome. So we're testing sensation. And then there's a couple different ways that you can do this. You can test by spinal level. So C5 to T1 is kind of the ones we're thinking about in the shoulder. But you can also test the sort of distal nerve branches. So we're thinking about radial, median, and ulnar nerve, right, in the upper extremity. So when you go through and you're testing by spinal level, you'll be able to just briefly touch the mid-deltoid for C5, and then it's going to be thumb for C6, middle finger for C7, pinky for C8, and then medial forearm for T1. And that's your C5 to T1. You've covered the whole brachial plexus, and you've tested the spinal levels distally, which is good. So if someone has some sort of radicular or cervical pathology that's inhibiting a spinal level, you might be able to pick that up with those distal tests. And then if you want to test the distal nerve branches, if you palpate, I'm not sure if this is actually an appropriate term, but I say dorsal thenar. So there's like the thenar eminence, right, on the palm of your hand. But then if you palpate the back of that, that's going to be a reliable area to test sensation from the radial nerve. And then your index and middle fingers are going to be reliable for your median nerve. And then dorsal hypothenar is going to be reliable for the ulnar. Depending on what images you're looking at, the sort of where the lines are drawn for all those nerves can be relatively variable. But from what I've seen so far, I think those locations are pretty reliable. And then I think I might have a picture of that, but we'll get to the pictures. I think it's in a couple slides. So you've tested sensation. You want to also test strength. And so that's myotomes. And that's just basically saying like strength, but by spinal level, right? So again, thinking C5 to T1. So for C5, you're testing the deltoid muscle. You'll be able to do shoulder flexion, often done kind of with the arms crossed, and then you can push down on the patient's arms. You can do elbow flexion for, I think this is all, sorry, my picture's blocking. Yeah, C5 and C6. And then wrist extensors is going to be C6. Finger extensors is C7. Finger flexors is C8. Intrinsics is T1. And this is kind of like a nice flow. I think it's really easy to remember if you can kind of remember the motions. So it's like C5, C5 and 6, C6, C7, C8, T1. And then you can, I hope you guys saw that. You can kind of go through all those motions. And then just a little bit of like a fun fact, if you're trying to remember like what spinal level innervates the finger flexors, this book that I was reading was like, so you're doing finger flexion. And the way you're testing it is your hand is going to come under the patient's hand like this to test it, right? And it kind of looks like an 8 when you do that. I thought that was kind of a weird thing. But anyway, so that's C8. That's how I always remember it. And then this is something you'll see a lot, especially in the inpatient setting, if you want to just do a really quick neuro exam for a patient such as someone who had a reverse shoulder or something like that. You can do thumbs up is a good test for the radial nerve, okay sign for the median, and then crossing the fingers for the ulnar nerve. Why is crossing the fingers good for the ulnar nerve? Does anyone know? What muscles does the ulnar nerve innervate in the hand?
The palmar interossei and the dorsal interossei.
Right, so the intrinsic hand muscles, and those are the ones that help us cross our fingers like this. So patients probably can't do it with both hands like that, but you can just kind of have them do something like this or try and cross their fingers, and that will generally be sufficient. And then reflexes are of course very important. So bicep is going to be C5 and 6. Also, C5 and 6 is brachioradialis, but they're kind of flipped in terms of the dominance there. And then tricep is going to be C7. If you want to Another fun trick for remembering bicep is C5. When you test the bicep reflex, that's going to cause like elbow flexion, right? So if you think of someone going like that, it's like you see 5, you see all 5 fingers when you test the C5 bicep reflex. Anyways, and then provocative tests. These are going to be very important for sort of nailing down specific locations of shoulder pathology, right? So thinking impingement sign or Hawkins. So this is when you're kind of forcing the patient into internal rotation while the arm is out in front of them. It's going to be testing for like impingement syndrome. And then we have empty can test. And I have a video to demonstrate some of these and some images later on. But remember, empty can is going to be for supraspinatus. We have drop arm also for supraspinatus. We can use those two to differentiate like rotator cuff tendinopathy versus a full tear. We have resisted external rotation or hornblower. Does anyone know the difference between those two and what new information you get by testing hornblower? That's okay. So resisted external rotation, we're going to be testing the external rotators. So that's primarily infraspinatus and teres minor, right? But once you do hornblower, which is essentially resisted external rotation in the elevated position, that's going to give you a better test for the teres minor. We have liftoff for the subscap. We have shoulder apprehension for shoulder instability, scapular winging, I asked you guys about earlier. So if someone has a long thoracic nerve injury or that for some reason or another have weakened or lost their serratus anterior, then scapular winging might be present. I mentioned the Sperling maneuver at the very beginning. When you want to start your shoulder exam, you quickly do a neck exam, do a Sperling. And then does anyone remember what AdSense is for? This is like a
Thoracic
DO
outlet.
thing. Yeah, exactly. Yeah. Okay. Cool. So then this is something that I wanted to be able to share with you guys too. So that way, maybe if I don't know if an attending would ask you something like this, but at least you can know that some of these tests, because especially with the shoulder maneuvers, the provocative maneuvers, it can be like rather challenging sometimes once you get out into the real world to like actually get a perfect test. And so what a lot of people end up doing is like sort of combining tests. So that way they take a really sensitive one and a really specific one and go from there. But I wanted to at least provide this slide for you guys so you can see some of the stats on some of the more common tests. So if you're thinking supraspinatus pathology, you can combine an empty can with a drop arm, and that's going to give you pretty good reliability in your testing. For slap lesions, you can do the O'Brien. I know O'Brien can be kind of confusing sometimes, but you have to make sure that you only get this 90% sensitivity if there's pain with the thumb down position. And the way I remember, it's like doing an empty can, but the arm is adducted instead of abducted. And then if the pain is relieved once they turn the thumb up, then you get that good sensitivity. Modified dynamic shear. Since we're short on time, I'll have to have you guys like look up a video of this, but essentially, let me make sure I can see. You're holding the patient in this position, and then you're applying anteriorly directed force to basically the glenohumeral joint from behind, and then you are passively lifting the patient's arm up and down. And if they get pain between, I think it's like 90 and 120 degrees, that's very specific for slap lesions. Okay, and then there's some information on impingement and capsulitis. Don't want to take too long. Okay, and I kind of mentioned this already, but why is it important to know the difference when you're testing spinal level versus nerve end branches?
Is it
That's okay.
to the level of where the injury is? Is it a root cause injury at the nerve root itself, or is it a little bit more distal in a closer to that actual structure of a muscle manifestation?
Yeah, exactly. So like in carpal tunnel, what is affected? Is it a spinal level or is it the median nerve? Right? It's going to be the median nerve. So you want to know what's the sensory and motor distribution of the median nerve, not necessarily the spinal levels that contribute to it. Because while that extra information is helpful, if you think someone has carpal tunnel, testing by spinal level might not be super appropriate. But if you think they have like a C5 radiculopathy, then you want to know how to test spinal levels, right? Because your median nerve, while it may have, I can't remember if for sure not, but while it might have contributions from whatever spinal level you're suspecting, it's not going to give you it's not the best way to test for that radiculopathy, right? So making sure that you know, or making sure that you have both of those, or at least kind of a general understanding of both will help you. That's not something that like someone would really expect you to have like mastered as a third year student, but this is all just kind of to help give you guys figure out where you have areas that you could benefit from studying and that type of thing. So here's an image of some of the dermatomes by spinal level. This is important to remember. We talked about this a little bit. So this one shows C5 kind of more anteriorly. I always test it like on the lateral deltoid, but that's like I was saying, it's like every picture is like a little bit different. But then we can remember, so we have C5 and then 6, 7, 8, and T1 on the medial forearm there. And you can see, I think it's the next one will show by nerve and branches. You can see why I say the dorsal aspects for the radial and the ulnar nerve, because while you can get them anteriorly, it's like kind of weird in some images. The lines change a lot on this, but you can see radial and ulnar like are half and half almost on the dorsal aspect of the hand. So I like to test it there. And then median, you can just test the tips of the index and middle finger. So that way, when you're testing distally, you know you're not going to like accidentally test a different nerve branch. Here's some images of some of the testing maneuvers. I know you guys are pretty familiar with a lot of these, so I won't spend too much time on these. But this is stuff you can come back to if you want, or you can just look up a video. I gave a similar presentation to like a different group of people, so I had like a slide explaining ultrasound. I know you guys pretty much know what ultrasound is already. And this was like a little sort of like mind thing to help people wrap their brains around how ultrasound works. I like to think of it as like a little waterfall, and then whatever anatomic structure it is like a rock protruding through. And then the image you see on the screen is this little waterfall. But anyways, we will quickly go over some ultrasound images and stuff, and then it's already 4, but I was super late. So how late do you guys normally go with these?
I mean, we've definitely gone over the allotted hour in the past before. So as everyone, if you have any other obligations, feel free to go. But the show is yours, Pierce, as long as you need.
Okay, yeah, and then you guys are like recording and stuff too?
Correct. Yeah, this gets recorded and uploaded to our YouTube channel afterwards.
Okay, very nice. Yeah, then I will actually try and almost slow down just a tiny bit. That way, just so if anyone wants to like actually watch, I'm not like skipping important stuff and I can continue asking questions. But if anyone wants to leave, I won't be offended. So don't worry about that if you have other commitments or that type of thing. But that way we can like get through the knee without cutting out a bunch of stuff. And I had a couple of videos demonstrating the exams that we can go over at the end too. So let's see. So we're going to look at some sample ultrasound, like anatomy and pathology. First of the bicep tendon. And we want to remember long head of the bicep tendon is what we're going to be looking at in these images. So something that's important to think about is we have the short head here that I'm tracking along, and then we have the long head. But why does the long head look shorter? Where we talked about this already, I think. What does this long head go on to attach to?
This is a super glenoid tubercle.
Right, yeah. So even though like from the exterior with not all the layers stripped back, it appears shorter than the long head, but it's actually longer because it goes all the way back into there, into the supraglenoid tubercle. All right. So these are some images that I just borrowed from Goosey, and I know you guys have. Do you guys use the Goosey curriculum as well? Okay, cool. Yeah, they took our class through it and it's super helpful. And I'm pretty sure they give us like 4-year access. So even once you're on rotations, you can still go back and work through that and that type of thing. And I did that before some of my ortho rotations too, just so I was a little more prepared for ultrasound. So we have a long view, longitudinal view of the bicep tendon here. What muscle would this be laying over the top of the bicep tendon?
Is that an anterior view? So is that subscap?
Well, think about where the probe is and what muscle you'd have to look through or cut through in order to get down to the bicep tendon. What's the most superficial shoulder muscle anteriorly?
Just the deltoid, no?
Right. Yeah. Yeah. Because we have the skin surface here, and then it's going to be part of the deltoid and then the bicep tendon. So now we switched to a short axis view, and you can see the groove here. All right. Actually, I think this is the groove here on this image, and you can see the bicep tendon sitting right there. And so it should look like a little, like a donut. And this one, I honestly feel like it's kind of hard to see perfectly, but you can see it a lot better in the next image where there's tenosynovitis. So we have fluid surrounding the bicep tendon in this image. I got rid of the model on this one because I had to zoom it in, but it's the same scanning position. So I also find that this is actually an easier scanning position when you're trying to find someone's bicep, because if you're thinking of the ultrasound waves as like coming across like almost like a knife or like a lightsaber or something, you can scan across and you know the bicep tendon, it has to go from, down where the bicep is and it has to pass in a straight line through here. So if you have a fan that cuts all the way across this way, if you just place it on there, you can almost always find this intertubercular groove area on your screen somewhere and then kind of relocate to it. Whereas if you start in the longitudinal view, you can see you have to be basically directly on top of the bicep tendon to find it. So if this person was a little bit more lateral, he wouldn't see it. So whenever if an attending ever slaps an ultrasound in your hand and you haven't practiced in a while, just remember start short axis first for the bicep. And then this is a long axis view of tenosynovitis, so you can see some inflammation there. And then we talked about the tendons already. Short head attaches to the coracoid. Okay, and then AC joint. So same scenario here, but the probe is now on top of the shoulder. Lots of things are blacked out because there's not a lot of soft tissue touching where the probe is elevated, right? But you can see a nice little gap. And pretty much to find this, I was trying to give some tips on like how do you find the bicep tendon? Start with the short axis view. To find the AC joint, pretty much it's just palpate it and put the probe right on top of it. There's not like a start here and then slide here like there is for some of the rotator cuff muscles. So you can just start right there on top of the AC joint. And then if you have a patient with a separation, it might look something more like this. There's a larger gap there. If you're questioning it, just look at the patient's other AC joint. And that way you can tell like what does their AC joint normally look like. And I can see Tariq's trying to find his AC joint. So if you're ever having a hard time on a patient finding the AC joint, I start on the scapular spine because if you follow it long enough, you'll get there. So like I said, you'll often be behind the patient. You can start on the scapular spine, palpate it around to the top of the shoulder to the acromion, and then you'll feel that little divot and that little nub where the acromion meets the clavicle, and then you've arrived. So looking at the supraspinatus, this is the anterior view that I showed you guys earlier. You can see the supraspinatus kind of peeking around here. And this is important because you have to put the patient in a particular position to get a good view of the footprint and insertion of the supraspinatus. You can see posteriorly here, it's pretty easy to see here. But what's unfortunate for us as medical professionals is tears don't often happen in this area where you could easily just put the probe right on top of them. Unfortunately, tears often happen in the subacromial space due to like compression, impingement, that type of thing, or even, a little bit more proximal or a little more distal to it. So you have to put your patient in this hand in the pocket position. I believe it's also called the CRAS position. And I put a little arrow on this image because you're going to start almost like you're scanning the bicep tendon. And then you'll move up a little bit more towards the ear, and then you'll track around the shoulder. And when they're in this position with their hand, like metaphorically in the back pocket, when you place it anteriorly, you should be able to see that insertion of the supraspinatus tendon. That's because it's superior and a little proximal at rest. But then when you internally rotate that shoulder, it's going to pull it down and anteriorly. So you can place it almost where you would have to look for the bicep tendon, but now there's going to be a supraspinatus insertion there. And then you can follow it around laterally and posteriorly, and you'll be able to just keep it on your screen as you go. It's something that takes a lot of practice. It's something that I'm still not super good at, so wouldn't be expected of you as an early third year. But if you want to really impress your attending, I guess you could practice that at home beforehand. And that is kind of the technique for following the supraspinatus. And here we can see full thickness supraspinatus tear, unfortunately, on this individual. And you can see the starting position that I was talking about. So hand in the pocket, and then you just put it right on that most anterior aspect of the shoulder. Okay, so that was some tips on the shoulder exam. I'm happy to ask or answer any questions you guys have, like either after or via email or whatever. But I'll just continue on with the knee exam. So again, anatomical planes. We don't need to review these again. Important things regarding movements of the lower extremity. It's going to, of course, be the medial and lateral or internal and external rotation. The abduction and adduction, flexion and extension, it's all pretty standard. Flexion extension of the hip versus the knee versus the foot. And at the foot, it of course becomes plantar and dorsiflexion. We're all DOs here, or future DOs at least. So I know this is kind of like second nature for you guys at this point. But super important when it comes to the clinical setting is going to be eversion and inversion. Anyone have an idea why having a good idea about these two movements is really important?
Ankle sprains, for sure.
Yeah. Ankle sprains, and then in the more unfortunate circumstances, it's going to be ankle fractures as well. Okay, and speaking of ankle sprains, ankle injuries, which of the two, inversion or eversion, is more commonly associated with ankle sprains?
Inversion.
Right. Let me go back real quick. Yeah, so you can see inversion ankle sprains. The foot much more easily falls into an inverted position, and then there's a few ligaments that get stressed over there. Does anyone remember at least what the ligaments are, or the most common, and maybe even for bonus points, the second and third most common injured? There's three primary ones, and then it's kind of in a special order.
It's
ATFL is the main one.
Yeah.
Yeah.
And then CFL, right?
Yes.
There's one more.
So
Yep.
deltoid?
TFL, PTFL.
PTFL. Yeah.
TFL.
Yeah. So deltoid is going to be one of the medial sided ligaments. So that's kind of that would be with more of an eversion ankle sprain. But yeah, you guys got it. The ATFL and then the CFL and the PTFL. And the way I remember that, I don't know if I have an image of it, but the way I remember it is it's like the two talofibular ligaments are kind of like one's first and one's last. And that is kind of just a little memory trick, I guess.
It's also in alphabetical order. That kind of helps.
Oh, big brain. Okay, yeah. So that's probably better. Probably a better way to remember it. But of course, most important thing, and probably one of the first questions you'll get asked is like, what one was most likely injured? It's going to be ATFL. Okay, and then important anatomical movements when describing the knees is going to be varus and valgus. You can use whatever sort of like play on words you want to remember the two. Once you get a few weeks into rotations, you won't have to use a memory trick. You'll just know what that shape looks like in your head, and you'll know varus and valgus. This is going to be super important on your orthopedic rotations when you're describing femoral neck fractures. They often shorten and then they fall into either a varus or valgus position. So that'll, when you guys get to those rotations, you'll start to see that a little bit more when you're describing sort of the angle between the two fragments of the fracture. Okay, so we'll go through sort of a similar pattern here. We'll start with the external or surface anatomy because this is what you're going to see when you examine your patient. If you find a patient with legs this muscular, let me know. But otherwise, this is what you should be kind of thinking about or visualizing in your mind's eye because these are the muscles you're going to be palpating. These are the landmarks you're going to be palpating. And ultimately, injury to those structures is what you're trying to figure out, right? So if you can visualize the anatomy, then you can probably find it and palpate it, and you can probably figure out what's going on with your patient. So we'll start at the top, of course. We have rectus femoris is going to be in the middle here. It's the most like midline and superficial. And then vastus lateralis and vastus medialis. And then what quad muscle lies in the middle here, deep to rectus? The fourth quad muscle. It's going to be vastus intermedius. So we have a lateral, we have a medial, and we have an intermediate. Okay. And then going along the lateral side of the thigh is going to be the IT band or the IT tract. It inserts on the proximal tibia, and it's known for rubbing on the lateral femoral condyle. That's how we get the runner's knee, or like the IT band syndrome. I guess runner's knee is kind of more patellofemoral pain, but get the IT band syndrome, right? And so you get the classic picture of like the runner that recently increased their mileage and they're having lateral knee pain. It's probably the IT band. But remember, the IT band runs all the way up to the proximal femur and even inserts on parts of the pelvis. So it's a very vast structure. Whoops. Okay, and then anteriorly on the lower leg, we have the tibialis anterior, extensor digitorum longus tendon. So making sure that you're able to see all those tendons individually. And then we have some of the hamstring muscles, biceps femoris on the lateral aspect. And then the popliteal fossa, there's going to be some neurovasculature back there. Also location of Baker's cysts. So that will be important when you're palpating behind a patient's knee. And then taking away some of the more superficial tissues and looking at the musculature, you can see the TFL, which inserts onto the IT band all the way up here. So you can see the IT band and associated structures run total proximal to distal on the thigh there. We have the greater trochanter. That's one of our nice bony landmarks when you're assessing someone's lower extremity. and that's going to be, of course, a proximal landmark on the femur. We can have a good view of the vastus intermedius here that I was asking you guys about a moment ago, kind of now that the rectus femoris is stripped away. And then, of course, we have our patella. This says patellar ligament. That's I think, debatable topic sometimes. Some people will say, no, if you like biopsy it, it's tendon and then all that kind of stuff. But patellar tendon, patellar ligament, kind of depends who you're working with. And then, of course, tibial tuberosity where it inserts. What's it called when someone gets a lot of pain and even some like osteolysis there at the tibial tuberosity? Might be a 14-year-old going through puberty, plays basketball, does some other.
Osteostratus.
Yeah, yeah. And you'll know it when you see this. When I saw it for the first time, you don't even have to talk to the person. You're like, that hurts, because you can see it protrudes. It's very prominent, probably not in everybody, but in people that have it pretty bad and chronically, it protrudes, and often quite further out than the other side does. Okay. So then going into some of the bony anatomy, I thought this was a good picture demonstrating some of the ligaments, but I wanted you to also be able to see like from pelvis to foot what the bones look like. So you can ignore kind of the arteries in this image, but I just kind of wanted to have a good thing to help you guys stick an image into your mind's eye of the lower extremity bones. So of course we have the ACL. ACL is more anterior and it prevents anterior translation of the tibia. Can kind of keep that in your mind. PCL is going to be posterior. It's going to prevent posterior translation of the tibia. We have the fibular collateral ligament, or the LCL, and then lateral collateral ligament, tibial tuberosity. I guess I'm like not even really following my boxes at this point, so I'll try to be a little bit more organized with this. Sorry, guys. Head of the fibula. This is something we all know very well as DO students, right? Fibular head dysfunction. What is? Never mind. I'll ask you guys about that later. So then, of course, we have the medial and lateral meniscus. Okay. And then looking at the knee from the posterior aspect, we have all the same structures. You can see the PCL a little bit more clearly now. You can see the medial and lateral menisci, ACL and PCL again. Okay. So what meniscus, medial or lateral, is more commonly injured and why?
Is it the anterior horn of the medial meniscus? Because you're generally like in deeper flexion when it's injured.
Yeah, so that's actually something I haven't read too much about in terms of the anterior versus posterior horn, but that I think about a lot, and I wonder why it's not talked about more. It maybe just my experience so far. I just haven't talked about it with somebody. But yeah, when you're in knee extension, the anterior aspect of the knee is going to be loaded more heavily as opposed to the posterior aspect of the knee, right? So, but the common answer to this question is that the medial meniscus is sort of continuous and tightly adhered to the medial collateral ligament. And so it's less mobile. And so when some shearing forces and twisting forces go in there, it doesn't have a way to slide around and dissipate that. And the force gets translated directly into the meniscal tissue. Okay, so, oh man, I meant to quiz you guys on some classic knee pathology, but anyway, so PCL injury, more common, I think, is like the dashboard type injury. You'll see plenty of patients like this when you work in the inpatient setting. They just get in a rear end car accident and their seat was too close to the dashboard or whatever. They may or may not end up with a PCL injury, but you'll see, people with lower extremity trauma and that type of thing. I haven't had a patient with this type of like hyperextension injury, but this is a known mechanism for PCL. And then, of course, for the collateral ligaments, this type of situation, contact sports is, of course, notorious for causing that. And then we all know ACL, of course, coming down in a twisting motion, causing ACL sprains or ruptures. Okay, and then we talked about sort of systematic approach to the interview. We don't need to go through this again. And this is another nice chart for you guys. Again, essentially going through bold carts, but this time it's for knee pathology. It's a little more extensive this time. And I will allow you guys to kind of come back to this on your own time if you want. You can screenshot it and then save it for when you're on clinical rotations and just take a quick peek at it before you go see a patient and or maybe even after when you're just trying to figure out what's going on. And that can help you there. So this is all relevant for your history. And then it's going to be the same approach. So when we get into the physical exam, we've talked to our patient already. We're starting to build differentials based on the history we have. But then you need to try and prove your prove your history wrong with your physical exam by doing a very objective and systematic physical exam, the same one you do on all your patients. And that will make sure that you get all the relevant information and get the correct diagnosis. So similar to with the shoulder, the way we examine the neck and then down to the elbow and even to the hand, with the knee, we want to make sure that we give some attention to the hip and the ankle because this is all obviously a very interrelated system. But when it comes to the knee exam itself, you're going to want to note on inspection, what's the position of the knee? Is the tibia sort of internally rotated or externally rotated? You might see like, you might hear that commonly described as like, are they pigeon-toed or something like that? Is there a flexion contracture? This won't be readily obvious until you have the patient get into a prone position and have them lay down. And then you might notice a flexion contracture. This is especially problematic when it's one side greater than the other. And then we talked about ankle motion. So is the ankle resting or is the foot resting in a pronated or supinated position, plantar, dorsiflexed? Unlikely to be resting in a dorsiflexed position because that would be kind of odd unless they had some sort of tibialis contracture. But and then is there symmetry or asymmetry coming from either trauma or muscle bulk or muscle atrophy? And then we'll go through kind of the palpation flow again too. This is the order that I like to do it in so I don't miss anything. And I'll go through that on the image with you. So this is your patient's leg. You're examining them in clinic. You did a little bit of looking at the hip already, and you're ready to do your official knee exam. You can start up high, palpating the quad muscles. Hopefully they have shorts on. You can see, is there any bruising or any obvious trauma up this proximal on the thigh? But you can palpate the distal thigh musculature, come down to the quad tendon. And also while you're palpating the thigh, you want to kind of feel along the IT band as well. So we're working proximal to the distal here. Did the muscles, did the IT band, did the quad tendon, and then we come down onto the patella, and then patellar tendon, patellar ligament, whichever you choose. And then the tibial tuberosity, of course, you want to palpate directly onto that. And then you can feel medially, which it's not marked on this image, but we'll get to it in some of the later images, but the pes insertion. So the pes anserine is an important anatomic landmark, and it's a source of pain for some people on the proximal medial tibia. All right, so it's going to be around in this area. I'll show you in a later image. So I've worked pretty much as distal as I want to go now for my knee exam, and now I want to check the medial and lateral sides of the knee as well as the posterior aspect. So at this point, I'll palpate the joint lines. Whoops. Palpate the joint lines medially and laterally. That's going to be important for meniscus pathology. And then around to the posterior aspect, I can feel for fullness back there if I suspect there's a Baker's cyst, or just tenderness in general at the hamstring insertions. So proximal to distal and then wrap around. And that's kind of the way I like to do it. And that's the posterior for the popliteal fossa. So, okay. So we did our palpation, and then we'll do range of motion of the knee. Full flexion, full extension. You can use a goniometer to make it objective if you want to get the degrees. And it's often reported in, let's say, like 5 to 130. You don't necessarily have to say like this many degrees of flexion and this many degrees of extension. You can just say, since the knee is sort of just like one fixed hinge joint, you can just say the knee joint moves from 5 to 135. Assess their internal and external rotation. You can do this of the tibia and fibula on the knee joint. So when the knee is bent to 90 degrees, you can test rotation there. But you also want to check internal external rotation of the hip too. Okay, so then we did our palpation pathway, and then we'll quickly go over the special tests again. So we have our dermatomes. L4, L5, S1 is going to be the medial, dorsal, and lateral foot. So that's working midline out laterally. You can get L4, L5, S1. Those are going to be probably the three most important for you to test. And then that was for spinal levels. But then if you want to do for end nerve branches, this is going to be a little bit more important in like the post-operative patient. Same with the shoulder too. It's like spinal levels are really important, especially in like the outpatient clinic when you're differentiating radiculopathy versus like OA or something like that. But in the post-operative patient, you're obviously a lot more likely to damage sort of an end nerve branch that's innervating a muscle or something like that, as opposed to a spinal level, right? Because if you're operating in this instance on someone's knee, you're probably not gonna, accidentally cut the L4 nerve root, right? You're gonna potentially hit, if you're operating on the knee, like the superficial peroneal or the common peroneal or something like that, right? So if you want to test sensation, dorsal foot for superficial peroneal, the first toe space, just right in between the first two toes for the deep peroneal, and then medial calf will be saphenous, posterolateral calf for sural, plantar surface of the foot for the tibial nerve. And I'll have images of these you can save as well. So for testing strength, again, we'll do spinal level. Knee extension is going to get L2 to L4. That's also your femoral nerve. Dorsiflexion is going to test the tibialis anterior. That's L4. It's also the deep peroneal nerve. All of the dorsiflexion muscles are deep peroneal. Toe extension, extensor digitorum longus. That's L5, also deep peroneal. And then foot eversion is going to be plantaris longus or peroneus longus, excuse me. And that's going to be the S1 spinal level superficial peroneal nerve. All the eversion muscles, peroneus longus, peroneus brevis, are going to be the superficial peroneal nerve. And then plantar flexion, of course, gastroc soleus plantaris, S1, S2, that's the tibial nerve. Then reflexes, the big two is going to be patellar tendon, which is primarily L4, and then Achilles tendon, S1. Provocative tests. Does anyone know what's anterior drawer and Lockman test for?
ACL.
Yeah, ACL. Posterior drawer, tibial sag, that's for the PCL. Valgus and varus stress, testing our collateral ligaments. And then McMurray tests for the menisci, patellar grind for patellofemoral syndrome, and then, chondromalacia of the patellofemoral compartment, and then patellar apprehension for patellar instability. And then J sign is also going to give us a sign for patellar maltracking. Is anyone familiar with the J sign?
Is that when you bring the knee into full extension, and if the patella tracks laterally, with the tendon, it'll actually look like a J?
Yep. Yeah, so that's pretty close. You'll want to ask the patient to contract their quads, so actively take their knee into extension. So you don't want to support them because otherwise the muscle is not on and it won't elicit the sign because it's created by an imbalance in quad musculature. So ask the patient to fully extend their leg, and then you'll see the patella track out laterally. And if you were to trace the path it takes, it kind of is the shape of a J. And that is an indicator of insufficient vastus medialis strength relative to vastus lateralis strength. And that's common in like runners, or just people that are active in general and that type of thing, people that don't have enough strength in their VMOs. And I think that's also sometimes a debated topic, but I think a lot of people will agree it's because the VMOs are weak. So here's just a image to help you visualize the dermatomes by spinal level. So like I said, we have L4, L5, S1. So when you're examining a patient, you can try and do more proximal spinal levels, but I think in most clinical scenarios, it will be satisfactory if you do L4, L5, S1. I don't think any attending will scoff at you if you only did L4, L5, S1, unless it's maybe like a neurology rotation or something. And then here is kind of same as we did with the upper extremity. Here's the innervation by the end nerve branches. So this picture is a little bit ugly, but this is the anterior view labeled here, and then here's the posterior view. So anteriorly, we can see the saphenous, the innervation from the saphenous nerve, and you can remember that because it follows the saphenous vein. So the saphenous vein is that one that's kind of anterior on the calf. In runners, you can often see this kind of protruding here on the medial aspect of the leg. And then we have the cutaneous innervation from the fibular or the peroneal nerves. So on sort of the lateral aspect of the calf. And then it branches for the superficial peroneal. Here is dorsal foot. First toe space is going to be the deep peroneal. And then looking posteriorly, we see even more of the saphenous nerve contributing, even more of the common peroneal. And then this is that sural nerve on like the distal lateral aspect of the leg. It runs essentially right along the like lateral border of the Achilles. So when you're doing a open reduction internal fixation for a fibula fracture, when you get onto some of your ortho rotations, and attending is going to potentially ask you what nerve you want to watch out for. And the ones you're going to be looking out for is going to be superficial peroneal coming down here, but then also you're going to be thinking about the sural nerve. Okay, so those are the two nerves that are potentially at risk when you do surgery for fibular fractures. Also, when you do a Stryer procedure where you lengthen the gastroc or the Achilles tendon to relieve a like plantar flexion contracture, or or just relieve tension on the foot, you're at risk of damaging the sternal nerve. So that's another common PIMP question there. Okay, and then these are some of the provocative tests that we were talking about. So I mentioned joint line tenderness. You can just palpate it. I think this image he's actually using his knee. This might be more for like varus and valgus stressing. I have never done that. I've never seen anyone really do that. But joint line tenderness, just palpating deep in. You want to make sure that you're actually between the femur and the tibia, and that will help you find the menisci a little bit better. Bulge sign is one I haven't mentioned, but it's for assessing effusion. So you can lightly stroke one side, the medial or lateral aspect of the knee, and you should be able to see any effusion or fluid if it's significant, kind of bulge out on the other side of the knee. This is a lateral view of the leg. You can see this is the area where people get IT band pain from IT band syndrome. Here's posterior sag sign after a PCL injury. So if you prop up the proximal thigh or proximal lower extremity, you can see potentially the leg sag down. We talked about Lachman's test and the anterior drawer test. There we go. So you can see those two. And then posterior drawer as well for a PCL. So I have a question for you guys. So between the anterior drawer and the Lachman, does anyone know which one is more specific for an ACL or actually more sensitive and specific for an ACL injury?
The Lockman.
Yeah. So Lachman's a little bit better. And here's some of the stats on that. So Lachman is about 81% sensitivity and 85% specificity for ACL tears, which is really nice. You can also use, if you do a Lachman's for high sensitivity and then combine it with a pivot shift, you can get a very specific sort of combination of exams. Is everyone familiar with like the difference between the ACL, the anterior drawer and the Lachman's test? Yeah, okay. I'll just, for those of you that might not know, it's described a little bit here. They're essentially the same test, except with Lachman's, you can see the knee isn't bent as much. We're aiming for about 30 degrees knee flexion, whereas anterior drawer is going to be closer to 90 degrees knee flexion. And just with the way that this degree of flexion loads the ACL, it's a little bit more specific. So if you're going to only do one, I would recommend doing this one because you're more likely to catch it. Pivot shift is a little bit more advanced, and I'm not sure that I could describe it to you without a video. It's a very satisfying test when you're able to see it demonstrated properly, but it's also kind of hard to elicit the true sign. And every time that you push that, if someone has an incomplete tear, it is like stressing the tissue. And so generally you don't want to do it too many times. So just before you do a pivot shift, I would ask your attending, is it okay? It's like if you see them doing it, say, hey, do you mind if I do it so I can see what it feels like and that type of thing. Just because if someone doesn't have a complete rupture, it's of course meant to stress the tissue. And you're using a long lever when you do it, so it could potentially further damage the ACL. And then the McMurray test, important for the meniscus, pretty variable sensitivity, but quite highly specific. So if you have a lot of joint line tenderness, which is pretty sensitive, we can see 91 or sensitivity 91 for if you combine the two of them, 91% sensitive and then 87% specific. And then kind of similar numbers for the lateral meniscus. So combining McMurray with joint line tenderness is going to be another good way to increase the rigor of the exam maneuvers that you're doing. And then let's see what we have next. Okay, so this was some more ultrasound. I'm just going to take a drink of water real quick. Thank you guys for bearing with me. We're almost there. Okay, so we won't go through that again, but then just some sample ultrasound images for the knee. You can see the probe is placed in a longitudinal view for the patellar tendon. You can see this green or this blue box represents where the probe is being placed on the patellar tendon. And then this is how the image is going to look. You have a nice view of the patellar tendon. You can see the patella and the femur, which is really nice. And of course, the infrapatellar fat pad. This is kind of satisfying compared to the bicep tendon. It's a little bit hard to tell what's going on because there's just like another muscle in the view. But in this, you have a lot of landmarks to see. You can tell exactly what you're looking at. And then short axis view, you can see a nice cross section of the patellar tendon. This is, of course, important. If someone gets patellar tendinopathy, you can see swelling around the tendon. Also, if they have a rupture, of course, you'll be able to see that there's a rupture there. And this is a short axis view of tendinopathy. You can see the swelling all around it and then the inflamed fat pad. And then IT band, just a reminder, remember I said it comes all the way up to the pelvis, interfaces with the TFL, and then comes down to the proximal tibia. So this is for some reason, the Goosey image said proximal femur, but I don't believe that to be true because you can see where the probe is. It's obviously the distal femur. And this is the lateral femoral condyle. So I think this image demonstrates very well the way that the IT band can rub on the lateral femoral condyle, and that's how we get that IT band syndrome. So we can see it's in a longitudinal view here. It's in line with the IT band, so you can see it coming across the top here. And then this one's labeled a little bit more, so it's a little more obvious what's going on. We have the IT band, you have the lateral femoral condyle. You'll see it running past because it doesn't end on the femur, it ends on the tibia, right? So it's going to go past the femur, but you can see how this condyle could potentially rub on the IT band. And then posterior structures of the knee. I mentioned the neurovascular bundle in the popliteal space. And here's how it might look on ultrasound. So you can take sort of a cross-sectional view here, and you can see your nerve, your vein, and your artery. There's generally, in all of us, right, there's a lot of structures passing through this area. If you're trying to find this, it can be kind of challenging to figure out what is what, because there's not going to be an A, a V, and an N on there on your ultrasound, unfortunately. But the artery is going to always be pulsating. So look for whatever structure is moving. If you hold still and you see something shaking in sort of a rhythmic fashion, you know that's going to be your artery. The vein is going to be compressible. So if you push down and you're able to find your artery, and then you slowly let go and you look kind of in that vicinity, you should see a little tube open up, and you'll know that's going to be the popliteal vein. And then the nerve, you can see it's not just like a dark circle the way the vein and the artery are. It's this kind of like patchy looking color, and it's different from the muscles that are nearby. And that's pretty much, at least with my level of experience, the best I can give you. So it'll be this kind of grayed out as opposed to a black circle, or as opposed to having striations in it like the muscles. And it'll be right next to the artery and the vein. And then this is what it looks like when someone has a popliteal cyst. So it's a big fluid collection produced by like an outpouching of the knee joint capsule. So you can see a big Baker cyst here. And then some of the muscles are labeled for us. Oh, I think I wanted to ask you guys too. Okay, this is pretty much the end of what I was going to do. And then I was going to show you guys these videos, but I wanted to ask the question, does anyone know what 3 muscles insert onto the PES? We had it earlier and I thought I had a slide on it, but I guess I didn't.
Is it sartorius, gracilis, and I'm for semitendinosus?
Yes, sir. Yes. Yes. So there's a nice mnemonic for that. It's
Say your
Sergeant
grace.
Goose.
Oh, I was scared.
Yeah.
What were you gonna say? What's your mnemonic?
Sergeant Goose.
Sergeant Goose. That's actually
Yeah.
better. I was gonna say your grace before T was the one I learned.
Okay, yeah. So that's super helpful too because it has the letters in it, but the Sergeant Goose is kind of fun because it's Sergeant like SGT, right? And then Goose, Pez Anserine is like Goose's foot. So it all kind of goes together. And then yeah, it's Sartorius gracilis semitendinosus. And so yeah, that's the reason I wanted to cover that is just because you're potentially likely to be asked that. So I hope you'll maybe remember. And then I had these videos. It's about 440. Are you guys okay with going over it? They're about 4 minutes each, and I'll put them on like 1.7x, and you should be able to follow it pretty well. And then we'll get through them pretty quickly, and then we'll be done. Okay. Oh, I'll probably have to reshare my screen though, right? Because you're still seeing my PowerPoint.
No, we can
No, we
see
see the video.
Oh, nice. Wow. Okay, that's great. Okay, and then I know I probably have to share my audio too for the video. Share computer sound. Oh, optimize for video sharing. Okay. Okay, yeah. So just let me know if you can't hear anything once the video starts, but I'll run it on 1.5 and let you guys watch. And just a note on this is you don't have to do it this way. This is just I wanted to try and show you guys how it can kind of all come together when you do your physical exam. And then you can just kind of take it and run with it and come up with your own way that you like to do it. So
Hello, my name is Pierce Desmond, and today I'll be demonstrating an
You guys
orthopedic
here?
knee exam. To begin your exam, first start by examining your patient for any signs of trauma or asymmetry. The asymmetry may come from differences in muscle bulk, muscle atrophy, or just differences in their anatomical features. After inspection, begin palpating the lower extremity. You can start at the lateral aspect of the thigh, palpating the IT band for any anatomical differences or for any areas of tenderness. You can then palpate partway through the thigh in the muscle bellies of the quadriceps, down to the quadricep tendon, the patella, the patellar tendon, the tibial tubercle, the pes anserine insertion medially, the fibular head laterally, and then the medial and lateral joint lines of the knee to the posterior popliteal space, asking again for any tenderness here as well. After inspection and palpation, you can begin to test your patient's range of motion. You can have your patient take a prone position on the table. First, check for any signs of flexion contracture. If it looks like their legs are able to extend equally on both sides.
Quick note on this. I didn't adequately assess for flexion contracture because her feet are supported by the table. So you would want basically the last bit of support to be around the knee to allow the knee to potentially or get to its full potential for knee extension. So this is not quite adequate. So just if you go to do that in clinic, make sure the feet hang off the edge of the table.
You can begin by testing the patient's degrees of knee flexion, and then bring the knee to 90 degrees, and you can check internal and external rotation of the hip. Internal and external rotation of the hip, like so. And then with the foot dorsiflexed, you can also check internal and external rotation of the tibia and fibula on the knee. After inspection, palpation, and range of motion, you can begin to test your patient's special tests, which would be dermatomes, myotomes, reflexes, and provocative maneuvers. After doing this, you can have your patient take a supine position on the table. With the legs fully extended, we can test our dermatomes. The medial aspect of the foot will be L4, the dorsal aspect of the foot, L5, and the lateral aspect of the foot will be S1, or pictured here, S1. After dermatomes, you can test your patient's myotomes. Since they're in a supine position now, you'll want to have them transition to a seated position. Once your patient is in a seated position, you can begin to test the myotomes. The first one will be knee extension, which will be the L2 to L4 myotome. Then resisted dorsiflexion for the L4 myotome. And then resisted toe extension for the L5 myotome. And then resisted foot eversion for the S1 myotome. After myotomes, you can test reflexes. The first one will be the patellar tendon reflex, like so, which will be primarily the L4 spinal level. And then next, you can check the Achilles tendon reflex, which is primarily from the S1 spinal level. After myotomes and reflexes, you can have your patient take a supine position again, and you can do a series of provocative maneuvers. First, ask your patient to relax their leg as much as they can, and then you can laterally and medially translate the patella, checking for any signs of patellar apprehension. After this, flex the affected knee to about 90 degrees, and then sit on the foot to anchor it, and you can perform an anterior drawer test, testing the ACL by trying to apply an anterior translatory force on the tibia. Then, similarly, you can apply a posterior translatory force, doing the posterior drawer test for the PCL. Extending the knee to about 30 degrees, you can apply a valgus force, testing the medial collateral ligament, and then a varus force, testing the lateral collateral ligament. For the last provocative maneuver, you can perform a McMurray test by flexing the knee and the hip. First, you'll test the medial meniscus by palpating the medial joint line, externally rotating the foot, and applying a valgus force as you extend the hip and knee, feeling for any popping or clicking, asking your patient if they feel popping, clicking, or pain. Then, back to your starting position of hip and knee flexion, you can palpate the lateral joint line, internally rotate the foot, and apply a varus force while extending the hip and knee, feeling for any popping or clicking, and asking your patient if they feel popping, clicking, or pain. That concludes all the steps of the orthopedic knee exam. I hope you find this video helpful, and thank you for your attention.
Cool. So that was my quick demonstration of the knee exam, and then we'll quickly do the shoulder one as well. And then I think that's pretty much everything I have for you guys. So we'll do this one real quick.
Hello, my name is Desmond, and today I'll be demonstrating the orthopedic shoulder exam. To begin your exam, first start by inspecting your patient, first for any signs of trauma, and then for any signs of asymmetry. The asymmetry may come from muscle bulk, muscle atrophy, or just differences in your patient's anatomy. After inspection, you can begin to palpate for any anatomical deformities as well as any areas of tenderness. First, have your patient turn around, and then you can start your exam up at the top of the neck near the C2 spinous process, feeling each spinous process down to about the level of C7, asking your patient if they feel any tenderness. Then palpate the paraspinal tissues for any tenderness, like so. And then you can feel the trapezius muscles, the rhomboids, the medial border of the scapula, down to the inferior angle of the scapula, the supraspinatus muscle belly, the infraspinatus muscle belly, the spine of the scapula, around to the acromion, and then come to the front of your patient and feel the AC joint as well as the clavicle anteriorly. Then palpate the intertubercular groove for the biceps tendon and the greater tuberosity where some of the rotator cuff muscles attach. After inspection and palpation, you can test your patient's range of motion. First, have them perform shoulder flexion actively, and then check and see if they have any extra range of motion with passive flexion. Then have them perform external rotation, also check passive, shoulder extension, also check passive, and then shoulder internal rotation, placing the arm between the shoulder blades, like so. We can turn around and demonstrate that one more time. Here, okay? After inspection, palpation, and range of motion, you can begin some special tests. The 4 categories of special tests will be dermatomes, myotomes, reflexes, and provocative maneuvers. To test the dermatomes, have your patient stand relaxed with their palms facing forward, lightly touch the deltoid for C5, the tip of the thumb for C6, the tip of the middle finger for C7, tip of the pinky for C8, and the medial forearm for T1. After testing dermatomes, you can move into myotomes. First, have your patient flex both shoulders and resist your push, shoulder flexion, testing the C5 myotome. Then elbow flexion for the C5 and C6 myotome. Wrist extension for the C6 myotome. Finger extension, pushing down on the fingers, for the C7 myotome. Finger flexion for the C8 myotome, having your patient curl their fingers like so and then pulling them out. And then the intrinsic muscles of the hand, fanning the fingers out like so for the T1 myotome, and then you squeeze like this. After you've done the dermatomes and myotomes, you can move into testing the reflexes. First, support your patient's arm like so. You can perform the biceps tendon reflex, testing C5 and C6, but mostly C5. The brachioradialis reflex, again C5 and 6, but more C6 this time. And then the triceps tendon reflex, testing the C7 spinal level. After the reflexes, you can begin some provocative maneuvers. First, come behind your patient and bring their neck towards the affected side for a spurling maneuver, asking if they feel any pain radiating down the extremity. Then you can move the head to the opposite side and extend the affected extremity, doing an absent maneuver for thoracic outlet syndrome. Next, you can ask them to bring their arm out in front of them with the palm facing up while you push down for the speed maneuver. Then, passively, you can hyperflex the arm for the NIRS maneuver. And then, with the arm flexed in front of them and then abducted about 30 degrees with the thumb pointed down, resisting your push down, you can perform an empty cam maneuver for the supraspinatus. Then, with the elbows at the side, you can ask them to externally rotate and resist your push to test the infraspinatus and teres minor. And lastly, you can have your patient turn around one more time and place their hand on their lower back, and then perform a lift-off maneuver, trying to see if they can lift their hand off their lower back to test the subscapularis. And that is the end of the orthopedic shoulder exam. I hope you find this video helpful, and thank you for your attention.
Okay. So, let me make sure there's nothing left. Oh, okay. We don't need to do these unless you guys want to. I think it's okay. I've taken enough of your time. But I'll try and skip them so that way if you guys want to go over them. Or I'll just do it real quick. We're already here. Might as well. Okay, so 55-year-old right-handed male presents with persistent right shoulder pain for 3 months after playing tennis, reports difficulty lifting his arms overhead and night pain. On exam, you get a positive NIR, positive Hawkins test, which I know I didn't cover those in the videos super clearly, but NIR and Hawkins test, limited active abduction and tenderness over the greater tuberosity. What do you guys think it is? You can just call out some answers and we'll get through it quickly. We don't have to be too extensive.
Impingement.
Subacromial, yeah, rotator cuff impingement.
Supraspinatus tendonitis.
Yeah. So those are all kind of like on a spectrum, right? So that's probably an important talking point. I have for mine, I've just put tendinopathy, but that is what it would be, tendinopathy in sort of the chronic setting, right? But first we start out with impingement, and that's caused by whether it's maybe scapular dyskinesis or a bone spur. So either improper biomechanics or an anatomic abnormality causing compression or narrowing of the subacromial space. And then over time, you get wearing of those soft tissues. You eventually get tendinitis and then eventually tendinopathy. So good. You guys were right on for that one. And then there's only 2 cases. So this is the last one. So 40-year-old male presents after a twisting injury while playing soccer 2 weeks ago. He now has a catching sensation, swelling, and difficulty fully straightening his knee. There's medial joint line tenderness, a positive McMurray test, and a mild effusion. Range of motion is limited by pain. What do you guys think it is?
Medial meniscus.
Yeah. So indicators here, of course, there's a mechanism. It's like falling and twisting. Patient complains of catching. There's medial joint line tenderness, which is classic. And then, of course, the positive McMurray. It's very specific, as we discussed for meniscus tears. So meniscus tear. Something that's super important is the timeline of swelling. You'll notice in medicine, the timing of everything is super, super important. Anyway, so, confusion can happen all the time if we're not constantly checking our timelines, right? And that's important for a scenario like this because what's the difference between rapid and slow onset swelling in the knee? What 2 things are on your differential for a rapid versus a slow swell of a knee?
You have like a reactive arthritis for rapid,
Could be.
like septicemia, or yeah.
What if, sorry to interrupt you. What if this patient had rapid swelling?
With rapid swelling, I think in the twisting mechanism, if the ACL maybe also got injured, took a piece of bone off, you have an active bleed, versus if it's a later on, it's just healing of the tissue that was damaged rather than just like a more active bleed going on inside the joint.
Right. So ACL and PCL classically cause like large rapid onset knee effusion, and they're associated with a lot of bleeding. Whereas a meniscus, it's more of swelling from just general inflammation. So they'll have swelling maybe that night, or maybe the couple days afterwards, depending on the severity of it. But ACL, if it's a full rupture ACL, it's almost instant. It's like swelling very rapidly. And so that's an important timeline thing you want to consider when you have a patient with knee pain. So yeah, this is in conclusion, I hope this was helpful for you guys and will be just kind of a nice way to like kind of bump back into, anatomy and MSK assessments and that type of thing as you guys get ready to go and crush your clinical rotations. I know it's going to be a great year for all of you guys, and I'm excited for you because it's been a great year for me. So I know you guys are going to have fun as well. If you have any questions for me, feel free to reach out, whether it's about this type of stuff or just like third year in general. These are my main references. I used a lot of pictures from Netter's Anatomy, also Netter's Orthopedic Anatomy. This is a really great book that you can get on like Book Warehouse or something, like usedbook.com or something. If you rotate with Dr. Dave Atkin, he'll give you a copy of this book, and it covers the neuro exam really extensively. It's like only a 70-page book or something like that, and you can just read it front to back in a couple days, and it will give you a lot of nice tips and tricks for the neuro exam and help you remember them. That's where I got the C8 and the C5 thing. It's kind of funny. Also, Stanley Hoppenfield is kind of a legend in the orthopedic world. There's a lot of other textbooks with his name on the cover. So you'll start to recognize it as you guys start to look at more books in your rotations. Obviously took a lot of images from Goosey as well. And then I don't think I had anything I needed to go back to, but you guys have these videos linked in the PowerPoint. I imagine Jack can share the PowerPoint with you guys, so feel free to watch those if you find them helpful. Otherwise, that's all I have for you. Thank you guys so much for sticking around. I know this was kind of a long one. So again, thank you very much. And if I can help any of you with anything as you go into third year and you're navigating things, let me know. And if I can't help you, I'll connect you with one of my classmates that potentially can.
Thank you so much. This was great, really. And thanks for teaching us for this long after